Okay, good evening, everyone. My name is Joe Matessa, and I'm with Boston Scientific. And tonight we are here to talk about male stress urinary incontinence with Dr. Brooke Edwards of the Urology group. So thank you, Dr. Edwards, for joining us. To all panelists, we have a chat available. If you have any questions or comments that you'd like to include in the chat, please type them in. You can either direct them to all panelists or you can direct them specifically to everyone. So with that, I will turn it over to Dr. Edwards.
Thanks, Joe. Well, welcome everyone. Thanks for joining. Again, I'm Brooke Edwards. I'm part of the Urology group here in the Cincinnati area. I see patients specifically in Northern Kentucky. And then also up in Norwood, I do have an administrative office and see patients at our surgery center. I came from Southern Indiana, trained in Indiana and out in Virginia, and then have been here since 2014, and then took over as our chief medical officer for the group in 2017. But just excited to be here. We really like the Cincinnati area and especially Northern Kentucky. And I'm glad to share some of this information with you because I often see patients for this issue, with them not realizing that there were options for treatment for this. And it may have been several years since they've had, surgery or radiation for prostate cancer or other things that have caused them to have incontinence. And they didn't realize they had treatment options after so many years. So I'm excited to share the information and go from there. All right. So male stress urinary incontinence, what is it? So basically, hopefully you can see my pointer on the screen. This is your bladder. This is kind of a side profile, and it goes down into your urethra. It goes out into the end of the penis. The bottom of the bladder, you have the prostate, and the urethra runs through that. Everyone has two sphincters, one that sits at the bladder that you really don't have much control over. Your body controls it itself. And then down below is another sphincter that is the one that you can control if you're trying to squeeze and hold your urine. So stress incontinence specifically is where this sphincter isn't working very well. Actually, when neither of them are working very well. But when they don't, then it allows you to lose your urine. So if you can imagine, if you sneeze, laugh, cough, lift something, stand up suddenly, there's a bunch of pressure that goes onto the bladder and pushes on the urine. And if your sphincter is not holding on tightly or squeezing appropriately, then the urine's going to leave the body. So we need to, as we discussed tonight, come up with a way to fix that, right? That the sphincter works better or a substitute for that. Stress incontinence is very common. Unfortunately, nearly 1 in 10 Americans will have urinary incontinence, and that rate continues to increase after the age of 60. All right, so what are some of the common causes that causes stress urinary incontinence? So specifically prostate cancer or prostate cancer surgery is probably one of the top causes. About 50% of men will report that they have some leakage right after surgery, having a prostatectomy or the prostate removed. About 9 to 16%, or on average, I tell patients about 10% of patients will continue to have incontinence after 1 year from the surgery time. There are other causes for it, neurologic problems, things like neuropathies from diabetes, spine surgery, back injuries, surgery that's done for what we call BPH or non-cancer enlargement of the prostate, sometimes can result in leakage. Radiation can, so even if you don't have surgery, if you have radiation for your prostate cancer, then you can potentially have leakage. And then pelvic trauma. So if you have a car accident with a pelvic crush injury to the bones, to the pelvis, or spinal injury, as I mentioned earlier, that can also cause some incontinence. It definitely can have a significant effect on quality of life with patients. There are many studies that show that those patients that have stress incontinence are often more depressed. They can be very distressed, have a lot of emotional concerns with it. And then often, one of the big things is they often feel more socially isolated, or meaning, they aren't getting out and doing things because they feel limited because of their leakage. All things that together cause issues with quality of life. All right. So specifically, what are the options for incontinence and prostate cancer? Well, let me back up just a bit. So specifically, why does a prostatectomy or prostate removal cause incontinence? So if you look at this picture, this is the bladder. And the bladder neck, as I mentioned, where the urine flows out to the urethra, goes right through the prostate and out the urethra. Around here, this yellow represents the nerves that kind of innervate or give the ability for the prostate to work, the erections to work, the sphincter to work, that does affect incontinence. So whenever we do surgery, we also often do a nerve sparing technique to try to save as many of these nerves, but you can see there's just really no way to completely leave them alone. So when we take the prostate out, you have this bladder neck left and the urethral stump left, and we bring that together and suture it together and make an anastomosis. So you're still supposed to have the sphincter here that should work. And then this sphincter here has been disrupted. So you're highly reliant on this sphincter working in order to keep your urine in. So what can be done about it? Well, there are several things that you can do that are pretty simple, that doesn't take too much work, but you just have to kind of think about. So one would be to reduce the amount of fluid that you take in, therefore reducing the amount of urine you make. So if you drink a whole lot, you're more likely to have to urinate more and therefore probably leak if the incontinence is an issue for you. So if you decrease the amount of intake, that can help. Obviously, we're encouraging people usually to increase their water intake. So it's a balance between those two issues. And then the other part is just, increasing how often you go urinate. So, not letting your bladder get full so it's less likely to leak very much. Another option would be to try to fix the problem, but non-surgically. Pelvic floor physical therapy is something I utilize a lot in my patient practice. I think it's a great thing because there's really no risk. It just takes your time to go. And it's a physical therapist, but they're very specialized in the pelvic floor. So they work with people that have pain in the pelvis, whether it's from surgery or other reasons relating to low back issues or spinal surgery. But they also will help you strengthen your pelvic floor. And they're also specifically the sphincter to help pull the urine in. They would work with a patient to teach them how to do Kegel exercises. But that's something you can work on your own and do those. But a lot of people have a hard time, especially after surgery or radiation, to activate those muscles specifically. So you think you're doing a Kegel exercise and you think you're squeezing the right thing in the right place, but it's not really working the right place. So a lot of times physical therapy will help with that process. And there's also something called biofeedback that can be part of physical therapy, but you can also see a nurse within our office, and they will work with you to basically put you through a biofeedback, meaning you try to do a Kegel exercise, and on a screen, it helps tell you whether you're doing it correctly. So you kind of get positive reinforcement when you are doing it correctly. The other option is going to be kind of coping mechanisms or management tools that we tell people, especially if they don't want to have surgery or they're not able to go to physical therapy. And that's when you're talking about the pads and the Depends. For some people, a catheter is an option. That's not always the best thing because it can bring in other risk factors, but it is out there. And then you also have penile clamps that can go on the penis and kind of close off the urethra and kind of is a substitute sphincter that will help keep the urine in. So of these things, the management options or coping solutions, as it says, can be somewhat problematic. A lot of people don't like wearing the Depends because they don't like feeling wet all the time. They don't like the moisture related to that, and they're always worried that, that there's an odor that other people can smell. That's a common complaint I hear. They're also very expensive. As you see on the bottom of the screen, 5 pads per day times 5 years could range, into $7,000 or more. So it's certainly not cheap. As far as catheters go, for some people, they're very uncomfortable. If you have a catheter, it has to be changed about every 4 weeks, either with a home healthcare nurse coming to your house or coming into our office for us to change it for you. Because it is a foreign body in the urinary system, it can increase your risk of urinary tract infections for some people. So it's not always, a perfect solution. And then the clamp, as I mentioned, for some people are uncomfortable. You can't leave it on there for long periods of time because it decreases blood flow to the penis. It's safe for short periods of time, but it can be very uncomfortable for some patients. So then we've talked about different behavioral changes you can make. We've talked about non-surgical managements that you can choose. That was the physical therapy, the Kegel exercises, and then we talked about different ways you can just manage the symptoms without really fixing the problem. But there are 2 other options, and I'm going to go through both of them here in a second, that are surgical procedures. The first one's a sling. So you sometimes hear female slings. There's also male slings. They're somewhat similar in idea, but they do work differently. The advantage of a sling for male stress incontinence is that, no one else knows you have it. Once it's in the body, you can't see anything on the outside. You can't feel anything on the outside. It's completely undetectable. It works very well for patients that have mild to moderate leakage. In other words, if you have 1 or 2 pads a day, I call that mild, all the way up to 5, about 5 or more pads a day. If you're really soaking 5 pads or more, that's pretty severe incontinence. And so the sling may help you significantly, but it may not get you dry. And we have another option that we can talk about, but for mild and moderate, it works very well. What's nice is it works immediately. As soon as we put it in, most people are dry, that day, the next day. It works on its own. You don't have to do anything else. It just puts things kind of, as I tell patients, back to normal, so that you urinate normally when you want to, and you can hold urine until you can get to the restroom. It has a very good success rate, and over 90% of patients are very happy and said they would do it again if they had the option. All right. So what is a male sling? So if you look at this picture, this is the bony anatomy of a pelvis. So this is kind of where your hip is over here and your hip's over here. This is where this is basically kind of the shadow of the penis if it was aiming up. So you can see behind there is the urethra as it goes down, and then it would circle into the picture and down into the bladder. So we put the sling through an opening in the pelvic bone that is basically done through an incision that's in each groin, and then one that's behind the scrotum. So we put the mesh, it goes right through here, and it kind of acts as a hammock to hold up the urethra, support it, and basically reposition it, we think, from the way it was before surgery. So helps support it in a way that keeps the sphincter working better and control your urine a little better. All right, so that's the sling. Now I said there was a second option, and that is what we call an artificial urinary sphincter, or what you may hear people refer to as an AUS, just the abbreviations for it. It is not anything new. For good and bad, we call it the gold standard because it's been around, I believe, since like the 1970s. They've made some mild modifications to it, but not very many because it works well. And people haven't come up with a better option than this because it does work so well. As far as how it works, I'll show you here a picture in a minute. But there's been many studies that have reported on this of long-term use with sphincter, the artificial urinary sphincters, or the AUS. It provides great bladder control. It's really, if someone were to look at you, they wouldn't be able to tell you have it. It basically gives you a sphincter, right? As it's called, artificial urinary sphincter, and because it's a cuff that goes around the urethra. And it works very well for mild incontinence, moderate incontinence, and even severe incontinence. So for the patients of you that have leakage that's greater than 5 pads, it depends a day, where it's just a lot of urine that's leaking, I usually recommend towards the artificial urinary sphincter because it does work so well for helping out that sphincter and keeping the urine in. All right, so how does it work? I'm going to show you a little video here in a second. But this is your bladder, here's your urethra, and it goes down through here. We put on a cuff that sits around the urethra, so it encircles it all the way. And then there's a tubing that goes down into what's a little tiny pump. It's about as wide as a finger, and it's fairly thin, maybe less than a centimeter or a third of an inch kind of thing. And that's hooked up to some more tubing that goes into a reservoir that sits next to the bladder. And there's some fluid in there, and it's saline. So it's the same kind of fluid that we would give you in an IV, if you needed fluid. And when it's activated or working, there's fluid in this cuff. And it keeps it kind of closed. So if you can imagine, it's kind of like a soft pillow because it's full of fluid, and it's closed around the urethra. And if you hit the pump, as you go to the bathroom, you need to pee, you squeeze the pump, it cycles the fluid out of the cuff and into the reservoir. You urinate just like you normally would. And as you finish, that fluid will automatically flow back into the cuff. And then now it's closed again and you won't leak. So it works very well. So let me show you a picture that might help, or a video. So this is a patient that has it in. As you see, you really wouldn't see anything on the outside. This is all under the skin. So you have your bladder. This is him squeezing it. It's cycling the fluid out of the urethra and into the reservoir, and he's urinating. As he's done urinating, this fluid will cycle back and fill that cuff and close it off. And you can see in this picture. And that went kind of fast there at the end. Let me see if I can. I might be asking a lot. I get anxious. All right, you can see the fluid in the cuff there. So urine's running out, and as the urine's gone already through, the fluid will fill back into it, and it closes it off. Okay. All right, so what to expect? Specifically with the artificial urinary sphincter and the sling, they're both considered outpatient procedures. With the sling, my patients go home the same day. With the artificial urinary sphincter, sometimes they'll stay overnight if I'm worried about a catheter, but it is considered an outpatient surgery. Both of them require an incision below the scrotum, as I mentioned. The artificial urinary sphincter does require a small incision up in the groin that has to heal, and it's fairly small. The sling requires the same incision below the scrotum, but then also a small one in each groin. After you have the surgery, you can get around the house, you can do small things. You just don't want to do anything strenuous. I don't have people lift heavy for about 4 weeks with it. But otherwise, you're not really limited too much on what you can do. As far as the sling, as I mentioned, it works immediately. But with the artificial urinary sphincter, we keep it deactivated or turned off for 4 to 6 weeks. And that's simply because we want it to heal before we turn that cuff on, because it's going to squeeze down on the urethra. And we want all those tissues to heal before we put pressure on them. So you do have to kind of understand you're going to leak just the same as before surgery. you're going to leak afterwards for 4 to 6 weeks until we turn it on. All right. So as far as the AUS, like I said, it's been around a long time. So there's been a lot of studies and quality of life studies that's been done on patients after they've had it done. So at this one, 94% of patients were satisfied with the device. Of those, 90% were satisfied enough even 10 years after they had the device. So most of these people are very happy for a long time. 90% of patients will have the surgery again. I mentioned that earlier. And 94% of patients would recommend it to a friend or family member because they think highly enough of it for that. Insurance-wise, for incontinence procedures with leakage, it's covered by insurance. I can't say 100%, but the vast majority of them are covered. It has been a long time since I've had a sling or an AUS denied on a patient that had incontinence. So I can't say, it's guaranteed everybody, but it is very uncommon for me to run into that trouble. In the office, if I met with you or you met with one of other physicians that did it, does a surgery, then what we do is we check with your insurance. We'll send in, check with the benefits, look into the cost for you, and let you know what it would be out of pocket before we'd ever proceed on. All right, so here are two patients. Herschel is one that has an artificial urinary sphincter, and he has said that it took him from 9 pads a day to 1. So he had severe incontinence. It made him feel like he could do things that he hadn't been doing. And it gave him the confidence to not have to worry about, whether he was going to have linkage if he went out and did things. As I mentioned earlier, remember the whole social issue as far as, feeling concerned that you go out. Well, if you fix the incontinence, a lot of times you build that confidence back up so that you don't have the worry of that. Fabio also had an artificial urinary sphincter, and he said recovery was very easy. It took me about a week and a half before I was walking around without any pain. I walked the first week, no scarring, no one can tell it's there. All right, so what are the benefits of the products? So ability, obviously, to achieve continence or stay dry. The ability to hold the urine until you want to go. So that way you're not feeling like every time you've been sitting, watching a baseball game or watching a movie that you've got to get up so often to empty the bladder because you don't want to get up at the end with a full bladder and leak everywhere. So it gives you that freedom to do that. It's both of the surgeries are, products that are inside the body, so people don't know they're there. With a sling, it puts things kind of back to normal, so you can do it on your own. The sphincter is one that you do have to push the pump to cycle the fluid, but otherwise no one would know it's there. Very high patient satisfaction. All the percents I gave you were 90% or above. And hopefully it would give the patient that struggles with this some normalcy and ability to feel confident in those activities so they can go back to living that life they had before prostate cancer treatment or BPH treatment or whatever it was that caused the issue. So I've talked about all the good things, so I always have to talk about the bad, right? Any surgery we do has risk factors. So we always talk about what the benefit is versus the risk. So specifically with the sling, sometimes you'll need a catheter after surgery and sometimes you don't. It just kind of depends on your specific situation. But the device can still fail, meaning we don't get the device in where it provides enough support, whether it's from your anatomy or whatever the reason is. So you still may have some leakage. Often in this situation, it improves it significantly, but let's just say you chose to do this and you have severe incontinence, hopefully it would get you back down to where you had maybe just 1 pad a day or just a safety pad. That's kind of common for patients that they're a little nervous to get rid of the pads altogether. So they wear a safety pad just in case, but they really don't need it. With the sling, a lot of times we talk about how there is a possibility that it works too well and makes you not be able to pee. Usually that's very temporary, but there's always a risk that could last longer. There's discomfort with the surgery, just like anything else. It's a surgery, so you'll be sore, but with a sling that is minimal. There is the one incision site down below and the one very small one in each groin. So you can have irritation from that as you would with any incisions. And the foreign body response, people ask about that. With these slings, you don't have a foreign body response as far as it causing issues, and typically allergic reactions aren't a problem. You can get an infection sometimes when there's a foreign body, so we have to be very careful of that and how we put it in, but that risk is fairly low, and the need for removal is very rare based on an infection. And then as far as for the artificial urinary sphincter, the device, it does kind of have moving parts with the fluid circulating, so it can malfunction. If there's a leak, it will not work and it would have to be replaced. Or if it doesn't work for any other reason, the cuff isn't tightening up enough for some reason. In theory, the cuff can erode or basically make an opening into the urethra. That's a higher risk for patients that's had radiation, but we still safely do use them. It's just one of those things we talk about because you have to be very careful with sphincters. If you have them, you don't want to have catheters put in, like say you have to have a heart surgery or a bowel surgery for a different reason, and they want to put a catheter in for the surgery, then we would want to turn off or deactivate the sphincter in order to put it in. Otherwise, there could be a risk of erosion. Similar to the sling, if the cuff is tight or you have a lot of swelling right after surgery, sometimes you have problems urinating and we need to use catheter. And then there's always the risk of infection, pain, and soreness, as I mentioned, just as in with any incisions. All right, so the summary of what we talked about tonight. So we know stress incontinence is when the sphincter doesn't work well, and it results a lot from prostate surgery, radiation, and other more traumatic neurologic issues with your spine. There are a lot of treatment options. Some just manage the symptoms. Some are more like physical therapy. And then there's the 2 surgical options that can take care of it. That being the sling, as I mentioned, for one, and the sphincter. And they both have good long-term results. We have a lot of credits